right, we'll now move to recurrent follicular lymphoma. We have lots of different options for these patients and a lot of exciting new treatments, some of which we've heard about already at the meeting. And the question is, how do we approach these patients in our practice? Those are my disclosures. I have consulted for some of the companies who are developing drugs in this area. So I think to look at this discussion, you really have to frame it around the patient's situation. And all patients with recurrent follicular lymphoma obviously are not the same. So I'll just give you two kind of ends of the spectrum. One is a 63-year-old male with follicular grade 2, has diffuse adenopathy, treated with R-CHOP and then observed. 5 years later, he has progressive adenopathy, not really bulky, in the 3-centimeter range. So 5-year first remission, 3-centimeter disease, good blood counts, negative bone marrow. So that's one scenario, and you can envision one set of options you might offer to that patient. However, now we change it, and I've highlighted things in yellow here that are the differences. So now the patient's 50 years old as opposed to 63, so you may or may not look at things a little bit differently. His remission was not 5 years, now it's 1.5 years, or was 1.5 years to his first regimen. Then he got Bendamustine and had a CR, but relapsed now. He's in his second relapse 1 year after having had R-CHOP and now Bendamustine. And so how you might approach these two patients based on the fact of the age, based on the fact of the number and the nature of the prior regimens and the time from the prior regimen to relapse, I think really influences where the array of options that you might consider for this patient stack up and what might come to the top of the list as to what you might approach this patient with. So I think these cases summarize some of the issues that we have to consider. The indications for therapy, does a patient need therapy and why? The bulk of the disease, obviously comorbidities. In follicular lymphoma, it seems like many of our decisions are focused around toxicity as much as efficacy and avoidance of toxicity. Obviously interest in and availability of clinical trials, and I think anytime you're getting ready to treat a patient with follicular lymphoma, particularly in the relapse setting, you have to go through the process of thinking about transformation, and whether that's just looking at the patient and saying, I don't think that's what's going on, checking the LDH, doing a PET scan to look for high uptake values that might argue for transformation, and doing a biopsy in those sites. All of those things, I think you at least have to run through your own personal checklist to decide, am I worried about transformation? Do I need to do a very efficient and comprehensive job at ruling it out? Or can I say, no, I don't think that's what's going on, and not worry too much about it? So the caveats as we look at, I'm going to present you data from a variety of different studies, but I think they are very, very limited in how they help us approach these individual patients. And I would say that of all of the data I'm going to present to you, they all have very big holes as we try to apply them to our population. So the prior therapies in these studies are very different. These patients from studies 5 years ago got a variety of different treatments. They may or may not have had prior rituximab. They may or may not have had prior R-CHOP or Bendamustine. And so how these apply to an individual patient today, I think, are unclear. But I think you have to say that with better upfront therapy, and if you argue that adding rituximab to our upfront therapy, or perhaps using either R-CHOP or Bendamustine, if we have better upfront therapies, those patients who relapse, you would expect are probably going to be worse patients from the standpoint of their prognosis. And as a group, although obviously individuals may differ, as a group are probably going to have worse disease than a comparable population time ago because of the nature of the fact that they've relapsed after better therapy. But again, that's obviously something one could debate. But we do have to look at these data in that sort of context. So what about giving patients chemotherapy? This slide is almost embarrassing to put up, but if you ask the question, how does chemotherapy work, or how does rituximab work in patients with recurrent indolent lymphoma, you get something like that. You also see that the most modern study on this slide is about 2005. So the idea of a patient, let's say, who hasn't had R-CHOP before and now has recurrent follicular lymphoma, and you're treating them with R-CHOP, how well is it going to work? Where you have this study at the bottom that says the response rate's 85% with a progression-free survival of 33%, but that goes back to 2005, which means those patients were treated in 2001, perhaps. And so how we can apply this to our patient today, I think you really have to basically say these have a response rate that's meaningful, but it's really hard to know what percentage of patients are going to have a good response and a durable response based on the way the population would come into these sorts of studies today. So Bendamustine was initially approved in recurrent follicular and indolent lymphomas, particularly in the rituximab refractory setting, and Brad Call presented this study. This was in the rituximab refractory population, one of the first studies to really define that as no response or less than 6 months to rituximab. So this is a more refractory patient population, a less relapsed patient population, with a median of 3 prior regimens. Half of them were chemo-resistant, so a little bit of a hodgepodge, but at least all of them were resistant to rituximab, and half of them were resistant to chemotherapy. The overall response rate's 84%. Median progression-free survival, however, 9.7 months. So if you're looking at this patient population and you say, okay, Bendamustine, it's a good drug, I can give it in my office, it's straightforward, and 80% of people will respond, great. However, half of them will progress within about 10 months or so. And so the idea that in a 50-year-old or even 60-year-old patient that you're going to get a long-term response out of Bendamustine is a debatable thing. Now, interestingly, this study has, like all studies with follicular lymphoma and indolent lymphomas, about 20 to 25% of people have these long-term remissions. And I have patients treated on this trial that are now 5, 6, 7, 8 years in remission at this point on this trial. Maybe not 8 years, I have to go back and see, but people that are still on remission from this trial. So there are patients that can have durable remissions, but I think the expectation is that most patients are going to relapse certainly within a year. So there are a number of novel agents, some of which I have time to talk about, some of which I don't. The novel anti-CD20s in recurrent follicular lymphoma are active. I think there are several studies that suggest they're in the ballpark of retreatment with rituximab, but I think personally the data that they are better than retreatment with rituximab is a bit debatable at this point, although there are a number of studies going on. I'm not really going to focus on the anti-apoptotic agents. They've been mostly studied in CLL largely, or the antibody-drug conjugates, which are certainly active in a variety of settings, but have different side effect profiles. I'm not going to focus on them too much, but mostly the bottom 4 things on this list. And obviously radioimmunotherapy is one thing you can use in recurrent follicular and other indolent lymphomas. You see that there are a number of studies here. The bottom line is that with RIT, with I-131 tosatumumab, which availability is becoming limited now, and yttrium-90 ibrutinib tioxetan, we have response rates ranging from about 60% to about 80%. Again, like Bendamustine, the median time to progression or duration of response somewhere around a year or just under it. But again, we have this very enticing 20% of patients, and this happens to be I-131 tosatumumab. There are similar data with yttrium-90 ibrutinib tioxetan. Again, this 20% of patients that have quite durable remissions. And so the bottom line is that for some reason there are some patients with just about anything you treat them with recurrent indolent lymphoma, that they will get this durable remission. You see it with Bendamustine, you see it with radioimmunotherapy, and I think we're going to see it with other agents as they come along. And the question is really, is it something about the agent in that patient population or just the nature of follicular lymphoma that you tend to see this? So again, for some people this can work like a charm, but for most people they're going to relapse within a year or so. So the timing of radioimmunotherapy, if you're going to use it and when you use it, certainly in older patients it can be quite helpful if you're trying to avoid more intensive treatment in particular. the benefits of this versus chemo-rituximab, that's certainly something that's not been well established in the relapse setting. No randomized trials of chemo-R, let's say, versus RIT. That's certainly one of the reasons why I think it's less commonly used. The acceptance in practice certainly has been an issue, and I think you do have to keep in mind the myelosuppression, the secondary cancers, and the cytopenias that occur. That figures into the decision. In some patients, it can be an issue, but for many patients, most patients, it's not really an issue, but you do have to figure that into your decision making. So what about other agents? We've been interested in lenalidomide, as have others, and in CLGB we conducted the 50401 study, which was originally a 3-arm trial, ended up being a 2-arm trial of lenalidomide alone or lenalidomide plus rituximab. As you know, lenalidomide has a variety of activities, direct and indirect, involving the immune system and vascularity, and directly against tumor cells. And so we randomized patients to get to either single-agent lenalidomide or lenalidomide plus 4 doses of rituximab. This was in relapsed, not refractory, follicular lymphoma, having had 1 prior regimen or more. This was a relatively favorable population. Most of them had low and low intermediate FLIPPs in the relapse setting. The time to progression, because they were not refractory, was a median of 1.3 to 1.6 years. Mostly advanced stage disease, relatively few had elevated LDH. So a relapsed population, not a refractory population. We found that the overall response rate to lenalidomide was about 50%. When you added rituximab, it went up over 70%. About a third of patients had CRs to the combination. And you can see that the median event-free survival was 2 years with the combination and about 1.2 years with lenalidomide alone. So this certainly suggests that this agent in a population of patients can give you quite a durable remission. This was, again, 1 year of lenalidomide and 4 doses of rituximab. And so, again, median follow-up here is relatively short, under 2 years. And one might wonder if we're going to see with time, again, this 25% of patients with these durable remissions in this study as well. So again, I think this is one interesting combination, and one that is now moving into the upfront setting in a variety of different settings, including the Alliance for Clinical Trials in Oncology and the GILA group through a study called Relevance. That's an international study randomizing lenalidomide rituximab to chemo-rituximab as initial treatment. So the hot area, or one of the hot areas that we've seen a lot of, is the B-cell receptor targeting agents. I won't spend much time on the background here, but basically we've heard about this throughout the meeting, but B-cell receptor signaling is important in indolent lymphomas. We have the Brutons tyrosine kinase inhibitor, ibrutinib, and the PI3 kinase inhibitor, Idelizab, both of which are operative. Those kinases are operative in follicular lymphoma, and so inhibiting those kinases makes a lot of sense. Now, what about using these drugs in patients with recurrent follicular lymphoma or other indolent lymphomas? So first, Idelizab, which is a PI3 kinase delta inhibitor, relatively specific for the delta isoform. It was looked at as a single agent in indolent lymphoma, 48% overall response rate, duration of response 18 months. It also has activity in CLL and in mantle cell, although in mantle cell the duration's a bit shorter. The principal toxicities of this drug include GI toxicity, liver enzymes, fatigue, and rash, but nonetheless, quite a reasonable overall response rate in recurrent follicular lymphoma, and also in rituximab refractory patients. We saw those data presented in Lugano. So in the relapse setting, we might say, well, what about combining these with other agents? We participated in a study where this was, Idelizab was combined with rituximab, combined with bendamustine, or combined with the combination of bendamustine and rituximab. Again, these are relatively standard agents to use in the relapse setting. Does adding this PI3 kinase delta inhibitor to these standard regimens improve things? And as you can see, the waterfall plots look quite favorable. The overall response rates look good, between the 70 and 80% range. If you look across the board, it's 78% or so. Again, obviously, you need a randomized trial to know, does Idelizab add to the backbone efficacy of these standard regimens? And so now there are a number of Idelizab trials going on. You've heard about some of these in CLL, but I'll just point out that in indolent lymphoma, there's a BR plus or minus Idelizab study and a rituximab plus or minus Idelizab study that will go on to look at these combinations and ask the question in the relapse setting, does adding a kinase inhibitor improve upon rituximab or improve upon the bendamustine rituximab combination? So ibrutinib you've heard about, again, the Brutons tyrosine kinase inhibitor. We've seen a lot of data in mantle cell lymphoma, a lot of data in CLL that you heard about, less data in follicular lymphoma. And this is from the early phase 1 trial. There were 16 patients with follicular lymphoma. And as you look across the board, the overall response rate was about 44%. If you look at those that got higher doses, up around 50%. About a third of patients had CR/CRUs. Median time of treatment, 7 months. Progression-free survival depends on the dose that the patient got. So this is clearly a very active or an active drug. This is a small number of patients, 16%. And so again, we have the same kind of pattern of studies going on, looking at combining this with rituximab, looking at it at rituximab refractory patients, and in other particular settings. And in the Alliance, we are looking at using this both in the relapse setting and in the upfront setting. We have a trial looking at Idelizab in combination with lenalidomide rituximab in relapse follicular lymphoma. We have a study of ibrutinib plus lenalidomide rituximab in untreated follicular lymphoma, and then a similar trial, Idelizab, lenalidomide rituximab in recurrent mantle cell lymphoma. So we're moving toward these combinations not only of the kinase inhibitor plus rituximab, kinase inhibitor plus chemotherapy, kinase inhibitor plus biologic combination. And, you know, on paper, these look like they're going to be very well tolerated from the standpoint of avoiding chemotherapy. It'll be very interesting to see how all of this plays out from the standpoint of efficacy and tolerability of these novel approaches. So then the question comes up, you're there with your patient in your office, you have lenalidomide available to you, you have rituximab, you have bendamustine, you have RIT, and then the question is, well, what about stem cell transplant? And we have lots of exciting new data with some of these agents. Some of these data are older, some are newer. Where does stem cell transplant fit into this? And if you're looking at, let's say, the Idelizab data or the ibrutinib data, and you have a clinical trial, you have a patient that's been through a number of different regimens, you're worried it's a young patient, you're not sure that they're going to fall into that 20% of follicular lymphomas that have these durable remissions. What can you expect with Idelizab? What can you expect with ibrutinib? What can you expect with bendamustine or lenalidomide if you're using those agents as far as the durability? When you're sitting there with your individual patient, what fraction of these patients can have a long-term remission? It may be some, but it's certainly not going to be all. And if they're comparable in efficacy as far as that, what's the quality of life? Is it better to get a stem cell transplant and be done with it, or is it better to be on chronic ibrutinib therapy? We don't know the answer to that, but it's certainly a potentially important question for patients. So I'll just remind you of the data, which is very, very, I would say, imperfect in transplant in recurrent follicular lymphoma. We have the CUP study, a 140-patient study, 10 years ago, looking at relapsed follicular lymphoma patients treated with chemotherapy, randomized essentially to chemotherapy, to high-dose auto transplant, either purged or unpurged. We won't get into that. But the bottom line is that transplant versus further chemotherapy, again, in 2003, which is really 2000 or so, transplant beat more chemotherapy with respect to progression-free survival, and transplant beat chemotherapy with respect to overall survival. So in 2003, you can use this imperfect study. You see it's a very small study, but one might make the argument, at least at that point in time, that there was an overall survival benefit to auto transplant in this population, so that would be the thing to do. Obviously, these data today are not convincing based on the size of the study and the time that's gone by since this study was done, but I do think it's an option that we need to keep in mind. And if you look at the St. Bart's data and Dana-Farber data, you have the enticing question of, we talked about, does radiation cure follicular lymphoma in limited stage? does auto transplant in recurrent follicular lymphoma cure patients, given that there are patients out here over 10 years that haven't relapsed? And again, so the question is, should we take a chance at potentially curing these patients with an auto transplant in the relapse setting, because of the fact that these patients are not likely to have durable remissions with most of the other options that we have. Now again, remember, this is 2007. So there are some more modern studies, one recently presented in JCO just this year. I don't think they answered this question entirely, but I'll present them to you. This is a study looking at recurrent follicular lymphoma in response, looking at rituximab purging or no purging. So again, this is from the era that purging was in vogue to study, and then looking at the outcomes of maintenance or no maintenance, but looking at transplant. What do you get in the more modern era with a transplant in a multi-center setting? And this is auto transplant. So the problem here is that this was rituximab naive patients. So you have to, again, take this with a little bit of a grain of salt, but at the end of the day, again, you see that no matter how the transplant was done and whether or not maintenance was given, that there were somewhere in the ballpark of about 50% of patients that had not progressed when you're getting out over 5 to almost 10 years. And again, so the question is, again, does this reflect a cure? Is this better than you would expect with some of the other options we've talked about in this patient population? There was another study presented from the Gila group that looked at auto transplant patients treated up front with essentially an R-CHOP type regimen. They looked at patients that had relapsed from this R-CHOP type regimen and then looked at what they got as second-line therapy. Some got an auto transplant. If you got an auto transplant, that was associated with a better progression-free survival and a better overall survival. So again, the problem here, not a randomized trial, auto transplant associated with a better outcome, not necessarily causing a better outcome. And then the age-old question, which we touched on earlier, what about allo transplant versus auto transplant? These are registry data from Kuhn-Bambisi, and again, going back to 2003, but a large number of patients, nearly 1,000 patients. And you see that allo transplant, earlier mortality, short-term mortality due to toxicity, and then kind of balancing out here in the long term with respect to the long-term outcome. So if you're going to do a transplant in that patient, do you do an auto? Do you do an allo? How do you decide? In the long term, they seem to be reasonably similar. And in fact, then we have the full allo in a younger patient versus the non-myeloablative. This is another transplant study, retrospective, 88 patients. The bottom line is that there were fewer relapses in the full allo group, a little bit more toxicity in the full allo group, similar overall and progression-free survival in both of these groups. And the key thing here is chemosensitive disease and no prior auto. Again, this is an allo transplant. So 2 years overall and progression-free survival of about 50%. Again, that's not quite long-term, and those are the data that we have with allo transplant. So this is, I think, my last slide. I think that at the end of the day, you have to have, like you always do with your patients and with follicular lymphoma in particular, I think the issue is really the pros and cons of, are you being hopeful that this patient will be in the minority that has a long-term remission with many of these regimens versus and wanting to avoid that short-term toxicity using a less intensive approach, or saying, look, can we raise the chance of a long-term remission by going through a transplant, by going through something more intensive? And generally in my practice, which may or may not be the right answer, I base this largely by how long it took the patient to relapse from the last treatment. There are many options for these patients. If they relapsed several years past their last treatment regimen, then probably you can do lots of different things and have a reasonable outcome. However, if they've relapsed relatively soon after their last regimen, not that they're chemo refractory, but they're relapsed, and I've arbitrarily said 2 years or so here, then I think those are the patients where you have to really think hard about novel agents, think hard about, is this patient going to get a stem cell transplant? Because if you wait till they're chemo refractory, fully refractory, it's going to be less effective. Or do you think about RIT, particularly in the older patient population? So with that, I'll stop, and thank you very much for your attention.